The approval of the Watchman device included an indication for use when there is a rationale to seek a non-pharmacologic alternative to warfarin. However, the approval also noted that candidates must be deemed suitable for warfarin. So the challenge is that optimal antithrombotic therapy following left atrial appendage closure is really an unresolved issue. So maybe a research letter in the October 25th issue of JACC offers some insight for you. I am with Dr. Josep Rodes-Cabau, who is from the Quebec Heart and Lung Institute at the Laval University in Canada. And we're here to talk about single antiplatelet therapy following left atrial appendage closure in patients with contraindications to anticoagulation. I guess the first thing is, what's currently recommended for these patients before we talk about this?
In general, for these patients who have this treatment, LAA closure, because they had either bleeding complications or a high risk of bleeding, the current recommendation is dual antiplatelet therapy for a certain period of time. Can be 6 weeks, 3 months, and then single antiplatelet therapy indefinitely. This recommendation, however, is completely empirical. There is no proof that these might be better to other antithrombotic strategies. It's important also to note that in patients without contraindications for anticoagulation, the current recommendation is still anticoagulation for 6 weeks. And then after that, if no thrombus is observed at the level of the device, then antiplatelet therapy.
So you and your colleagues decided to just see what would happen in a group of people who are at high risk for bleeding if you use just aspirin, correct?
Aspirin or clopidogrel. This was a very small pilot study with 31 patients that received about 2/3 of them aspirin, 1/3 clopidogrel. And the idea was really to evaluate these patients systematically with transesophageal echo at 6 weeks and then following the patients. What we observed that in this population there were no really major periprocedural complications, but this is probably not related to the single antiplatelet therapy. What is important is that the transesophageal echo at 6 weeks demonstrated the presence of device thrombosis in one patient, which is around 3% rate, which is similar to other studies that have used dual antiplatelet therapy after these procedures. We have for these patients a mean follow-up of about 2 years, and in these 2 years there were no episodes of a stroke or systemic emboli, and there was one patient who had a major bleeding. This is much less than the expected rates of annual rates of stroke based on CHA2DS2-VASc score or bleeding based on Hasbleed. Meaning that as a proof of concept, I think that we were able to show that single antiplatelet therapy may work for these patients, which all of them had high risk of bleeding. Many of them had major and several episodes of bleeding before the procedure. And when you give to these patients dual antiplatelet therapy, the risk of having a bleeding episode is probably close to that observed with anticoagulation.
So can you describe the patients who were in this study?
Patients were exclusively patients who had either a high risk of bleeding, defined as a Hasbleed over 3, or had prior episodes of bleeding. Sometimes this was also combined. The vast majority of them had prior episodes of major bleeding, some of them life-threatening bleeding.
So this is a pilot, obviously. What are you looking for now? Are you going to do a larger study?
The idea is to continue with this observational registry with a larger number of patients. Now a larger number of centers are already involved, and we expect to have a significant number of patients within the first year or two. The final goal would be to launch a randomized trial The problem here is that it will need a lot of patients, because if you design a non-inferiority trial compared to the current recommendation, the numbers are relatively low in terms of device thrombosis and bleeding episodes, meaning that, and the recommendation for dual antiplatelet therapy is short term. It's not really long term, where you can have more differences, meaning that it might be difficult to end with a randomized trial, but maybe we will try. Up to now, we are trying to increase these cohort, because we think it's important. Some of these patients came to us, and the neurologist, after a cerebral hemorrhage, said, no way that this patient will have dual antiplatelet therapy, because the risk of a recurrent episode of bleeding is really too high.
So what's your take-home message at this point?
At this point, I think that, and this has been adopted by many centers, is that probably single antiplatelet therapy seems a reasonable strategy for patients undergoing left atrial appendage closure because of either high risk of bleeding or because of contraindications to anticoagulation. The data is limited, but still the data we have with dual antiplatelet therapy, again, is a recommendation that has been completely empirical, with no really a lot of evidence.
Well, we now have some data, and it is in the October 25th issue of JACC. Please check out this particular research paper. For CardioSource World News, I'm Executive Editor Rick McGuire.